Good morning, everybody. I hope everybody's doing well, and I hope everybody enjoyed last evening. It's somewhat difficult to get a large restaurant where everybody can fit. So I know it felt a little bit disjointed, perhaps, but hopefully everybody had a good time and enjoyed their meals. It is an honor to chair this session, which is a joint session between the DNSG and ESPEN. And it's an honor to have the past chair of ESPEN, Rocco Berizzoni, join us and present today. And it's also an honor to say that he has become a new member of the DNSG. Thank you. My chair is Harris. He'll be co-chairing this with me. And I'd like to invite the first speaker up, a good friend and very important member of the DNSG, Jeff Mechanic. He'll be presenting evidence for diabetes-specific formula in diabetes management. Jeff, please.
Great. Thank you, Cyril Harris. I'd like to thank the organizers for inviting me. This is my favorite conference of the year. Ottawa is great, and just seeing a lot of old friends. Wonderful. Jordy, amazing talk. That was really good. All right, what I'm going to do is I'm going to speak about diabetes-specific formulas. But, you know, this is a kind of stale topic at some point. It's very linear. It's about taking in something that is supposed to be good for diabetes and then looking at effects on diabetes. And sure, there's more studies that come out, but what I want to do is I want to blur the lines a little bit for this talk today. I want to talk about first the double burden of malnutrition as the backdrop, as the context. So when we talk about malnutrition, we're actually talking about undernutrition and overnutrition. They don't have to exist at the same time, but they can certainly exist together. I want to then go through the evidence real quickly up to where we were last year and then bring us up to date with an update of what's happened in the past year. And the second line that I want to blur is exactly what is a diabetes-specific formula, because when you look at the data and you look at the studies, they're not all the same. Some are low calorie, some are used for other intents, and they're sort of incidentally included in some of the large studies. Now, this is a chapter that's from our lifestyle medicine book that just came out. And in this chapter, what I wanted to do, and this has been a big problem within the nutrition space, is the lexicon. We're using a lot of words that really need to be disambiguated. We're using words like malnutrition when we really mean undernutrition or malnourishment. But what does that mean compared to malnutrition? So what we did is borrowed from our driver-based chronic disease models that we used for abnormal adiposity, dysglycemia, cardiometabolic, hypertension, lipid, et cetera. And actually a recent paper we just got published on critical illness-based chronic disease. So here for malnutrition-based chronic disease, stage 1 is risk for any imbalance. Stage 2 is the imbalance. That's what malnutrition is. Now, I'm going through it now because I'm going to be using these words during the talk, and we need to know what those words mean. Stage 3 is the phenotype. That's malnourishment. That's when you actually start to lose some of your lean mass. You have body composition changes, some of the biochemical parameters. And stage 4, that's complications. That's what you're really trying to prevent. You're trying to prevent the malnutrition-related complications. So the second line, what is a diabetes-specific nutrition formula? And you can define them in various ways. Operationally, they're designed to improve glycemic control. Incidentally, they also help with other cardiometabolic risk factors. There are mechanisms that can be tracked looking at glycemic excursion and those that may be more susceptible with beta cell defects. It's evidence-based, it's guideline-directed, oftentimes components of more global composite lifestyle interventions like in Look Ahead, for instance. And then the ingredients are somewhat defined, but not all diabetes-specific formulas have the same issues. Generally lower carb, generally higher protein, slowly digestible and low GI, carbohydrates, more fiber that's in there, healthier fats, the MUFAs, the PUFAs, omega-3s. Protein is a high biological value protein. And even micronutrition is specified that there's maybe more chromium and more micronutrients that help out with insulin receptor signaling. So let's sort of breeze through some of the older data that we reviewed last year. Indeed, in this outpatient study, there are benefits on glycemic excursion, that you have a blunting effect. When you look at an inpatient study, you can see the same sort of phenomenon, that in the inpatients, and this would be non-ICU patients, that you can see that there's a blunting of glycemic excursion. Here we have critically ill patients, and actually a relatively negative study, although the average CGM readings were a little bit lower with the diabetes-specific formulas. In general, there weren't any other significant differences. This is an important point to keep in your mind as we go through this talk about the ICU. And here, John and his group went through and at this point sort of reviewed the information, did a systematic review and meta-analysis, looking at the extent data at the time. And indeed, there were benefits in the overweight and obese population. And in a later study, I don't have the slide here, John, you did the same kind of study for prediabetes and sanctioned by this group. We then did also with Jarvis, who was on a lot of these papers, we did more of a narrative review a few years later, looking at some of the global benefits of diabetes-specific formulas. And we found not only effects on weight and glycemic control, but also cardiometabolic parameters. Two other studies, just to mention, look ahead. The diabetes-specific formulas were used there in terms of meal replacements, and the benefit, as you just heard, when you had the population over 10% of weight loss on cardiovascular outcomes. And another paper, a shorter study on RCT, only 12 weeks, but showing benefits on visceral adiposity. In fact, the guidelines are imbued with comments about diabetes-specific formulas and the fact that you should either consider them, or we don't mind if you use them, or we favor you use them. There aren't really strong recommendations, but they've sort of infused themselves in these various expert consensus and white papers. Here's a summary from ESPEN looking at diabetes-specific formulas and basically saying they may be used. If you look at the last line, they may be used in patients with diabetes. Dr. Preiser actually made a comment for ICU, and this is why I wanted you to remember that study, that you really don't see these benefits in patients who are critically ill. And in fact, in the ESPEN guidelines, not for nutrition, but the ESPEN guidelines at the time for critical illness said, look, you don't really need to use these specialized formulas. We really need to take care of some of we have our hands full, first of all, in the ICU, whether you need to feed early with protein, whether giving too much food early on is actually bad for you. So there are other issues in the ICU besides glycemic control at this point. There are some real-world practice studies. A lot of these are from Spain, looking at benefits. But here, what I'm doing is I'm picking papers where the population actually had malnutrition. And in fact, through some composite markers, there was malnourishment. And indeed, there were benefits on glycemic control. And here's another study where there are 13% or so were severely malnourished. And in fact, there were some improvements in glycemic control using the diabetes-specific formulas. In this Italian case series pretty recently, this was home and using it as a tube feed, as enteral nutrition, showing benefits not only on glucose control, but lipids and also some renal function. So there's more of an effect of this intervention than merely glycemic control, as the name might have you think about. In this study in patients without diabetes but with stroke, compared to the controlled formula, which in a multivariate analysis was associated with hyperglycemia, there was this blunting of glycemic responses and improvement, salutary effects on glycemic control. Now what I want to do is just wrap up and pull this together. I want to start thinking about the use of diabetes-specific formulas, not in isolation, but rather in conjunction with technology. So this is a study on digital twin technology, which is, and you saw from my disclosures that I'm on the advisory board for Twin Health. This is from a multi-center study in India, and looking at patients with type 2 diabetes on a variety of different kinds of interventions with a 72% rate of complete remission, defined as 3 months, completely normal metrics and no medicine, whatever, de-escalation, coming off of your medications. And coming off of your medications with this technology, with the continuous glucose monitor, the accelerometer, digital scales, digital hemodynamics, and a lot of motivation, a lot of prompting, nudge touch technology. We actually, I can say, just got our Cleveland Clinic paper and RCT accepted to New England Journal of Medicine Catalyst. That'll be coming out shortly with similar diabetes remission rates. This is a particular study from endocrine practice showing mobilization of ectopic fat with this weight loss and with the improvements of glycemic control. But together with changing the way, personalizing the nutrition, essentially mimicking what's happening with these diabetes-specific formulas. This is my last slide. And what I want to do is show you where we're heading, perhaps for next year. There are some ongoing studies looking at this blending of these customized formulas with technology, the digest carb count study, and then a new pilot study, the drop study, the feasibility study at Joslin, been completed, the RCT in progress, showing improvements in weight, improvements in A1C, blood pressure, and actually an option of 0, 2, or 4 servings per day, and a preference to actually take in more by the patients in the study. And with that, let me conclude. The use of diabetes-specific nutrition formulas is an evidence-based intervention. We're well beyond just anecdote. This is an evidence-based intervention in a variety of clinical settings, not just diabetes, but including diabetes type 1, type 2, even gestational diabetes. There are studies, cardiometabolic health, via the dampening of the postprandial glucose responses and nutritional pharmacology. Let me just parenthetically say, this is why we see some differences in South Asians where there may be decreased beta cell mass and more of a susceptibility to postprandial glucose rather than fasting glucose. The dual burden of under and over malnutrition, MBCD, malnutrition-based chronic disease, particularly in the context of cardiometabolic risk. You saw in that first slide the overlap of malnutrition disorders, and cardiometabolic risk. And that's the way we have to think, not to be siloed in various diseases, but really looking at a lot of these chronic diseases in a multi-morbidity model. In the US, you have 60% with at least one chronic disease, 42% with 2 or more, maybe 12% with 5 or more chronic diseases per CDC data. And lastly, digital twinning in combination with healthy eating, dietary patterns, medical nutrition therapy, and precision nutrition with meal replacements and these diabetes-specific formulas is an active area of research, so-called research gaps. Thank you.
Thank you very much. Thank you very much, Professor Mechanic. And I have the pleasure to invite Professor Guaraggioni in order to give his talk. It will be on the dietary approaches of the management of sarcopenic obesity.
Thank you very much. Good morning, everyone. Thank you, dear moderators, for the introduction. I was touched by your words, Professor Kendall, dear Cyril. It's very meaningful to me to be here. It's a great honor to be invited, and I take them on behalf of ESPEN. For ESPEN, it's really important and appreciated to have the opportunity to collaborate with the DNSG. I can tell you I'm no longer the chairman, but the current execom of ESPEN has shares the enthusiasm to continue this collaboration. So I hope that we will continue for many years to come. Although I might have actually let's say, double hat from now on. It's really an honor also to be part of the DNSG starting this meeting. So thank you really for the introduction and the, let's say, welcome that I feel is very appreciated and important. I already used 1 minute of my time, precious time, so I hope that but Professor Mechanic was even more concise, so I hope that I might manage. Dietary approaches for the management of sarcopenic obesity, okay. Big topic, important topic. This is my disclosures in the last 2 years. I would like to start with this complex slide, but with 2 messages mainly. One is that sarcopenia comes from the geriatric world, and it's now currently globally accepted as a definition not only of a reduction of muscle mass, but maybe even more prominent, a reduction of muscle function, meaning muscle strength and mass. That's sarcopenia. And also, you can see on the left that sarcopenia implies some important nutritional deficiencies, especially in the absence of obesity. It's a given. We have often a deficient diet in older adults in respect of calories, in respect of proteins and macronutrients. So that's an important component of sarcopenia, this deficient nutritional state that we may use for treatment. Sarcopenic obesity, of course, introduces a complexity of the obesity component, which is still retaining the nutritional deficiencies that are important. We know that they may happen also in obesity, and the low muscle mass and function may be treated, or they may benefit from, let's say, addressing these nutritional deficiencies that are more or less the same that I mentioned before. I will go into details. But we also have the topic of calorie excess that might become a treatment. I mean, reducing this calorie excess might become a treatment for sarcopenic obesity, because there's not only an addiction of 2, let's say, separate entities, but there is a complex pathophysiological interplay between obesity, excess fat, the metabolic derangement, and loss of muscle mass and function, which will also negatively impact the risk of gaining more fat. So the complexity is there, and the nutritional complexity is much bigger, I think, than the one that we need to address for sarcopenia. So I will start with the deficiencies, and we know that protein is, I would say, even more or less intuitively, as we're talking about muscle mass and strength, one of the key components, if not the key components. And we have a knowledge in general that we need to ensure an adequate protein intake. I'm choosing words carefully here, or increase protein intake to make sure that our patients do not develop sarcopenia, or we may treat effectively sarcopenia. There are some seminal studies that have shown that a protein intake higher than 1 gram per kilogram body weight, this is an ABC study, but there are others, may prevent or reduce or slow down the progression of muscle loss, which is, again, inevitable, almost inevitable in aging. And this is one issue that we have to face again and again for sarcopenic obesity. Most of the evidence that we have comes from older adults without obesity. So that's sarcopenia. We lack really high-quality evidence, trials that have addressed the role of nutrition in sarcopenic obesity, both from prevention and also intervention points of view. Of course, the results from the PREDIMED Plus may help us. We hope that there are more and more studies coming, but I have to say that the evidence for sarcopenic obesity is limited. On top of that, we have shown, the evidence has shown that we need to have an adequate protein intake, more than 1 gram, let's say, but the longitudinal impact of this, let's say, higher protein intake has been challenged in further analysis. I would just summarize saying that there are probably confounding factors in longitudinal observations, especially in older adults, some bias that may be difficult to recognize. You can see here that further analysis of the ABC study show that, okay, this protection may be time-dependent, sex-dependent, ethnicity-dependent. We don't show it universally, let's say. This is another example, the Newcastle 85 study. It's old, I would say, adults. And again, there is a difference in the phenotype at the beginning of the observation, but again, the longitudinal impact of this higher protein intake is difficult to confirm. So we have, again, some lack of strong evidence. Here again, the female sex appears to be more benefiting from the higher protein intake, and the impacted follow-up is really difficult to assess. So these complexities are there. and again, the lack of obesity-specific data. There is also an important issue that we are all aware in this group in particular. These studies have not really directly addressed the protein quality issue, and that's important to consider because we know that, for instance, whey may ensure higher bioavailability and especially higher pulse of anabolic impact with the faster digestion. This is also introducing another important component, which is training, exercise, in particular resistance training in this meta-analysis. We can assume that all of our interventions will be more effective with resistance exercise, but again, we have no direct evidence about that in older patients or sarcopenic patients with obesity, and that's a limitation. This is again higher protein and resistance exercise, also introducing another variable potentially, the duration of the intervention. Of course, we know that duration of treatment of obesity is a key issue. It's coming up again and again also with the new medications, and so we need chronic interventions, and longer duration may ensure a better protection of muscle mass, but this again is non-obese older patients. We lack the evidence for our, let's say, sarcopenic obese phenotype. But again, I would like to come back to reality, and I think that we need to make some recommendations to the clinicians that need, including ourselves, to treat the patients. So I think that there are more and more consensus initiatives that have embraced this concept of the more than 1 gram per kilogram body weight. By the way, I think that maybe we cannot exclude that some of the discrepancies in the longer term follow-up results may be due to maybe we need even more protein to protect muscle mass, but we don't know, maybe more than 1.2 up to 1.5. We will see some examples later. So these are examples from the ESPEN community, for older adults, 1 to 1.2, and sarcopenic obesity. This was the paper that we published 7-8 years ago, starting with a discussion on sarcopenic obesity. More than 1 gram is what we recommended, but it was consensus-based and definitely not evidence-based, with ideal body weight as a denominator, by the way. This is bringing me to another issue, which I think is very important and maybe is a little bit neglected sometimes. Which weight do we use in obesity to normalize or to make our prescription? Is this actual body weight? I think that the risk there is over-prescribing. Ideal body weight might lead to under-prescribing sometimes. So I think that in ESPEN, we have embraced in our guidelines, and I'm happy to say that we have discussed this also with DNSG in our joint initiative, that maybe adjusted body weight could be a lesser evil, or maybe reducing, minimizing the potential for mistake. And adjusted body weight can be, again, defined as ideal body weight plus 25, some people say more than 25% of the excess body weight in obesity, which may account for the lean component of excess body weight, which is there. So it's another important topic. Okay, calories. What about calories? I think that for obesity, we have this bias. We need to restrict the calories. We hear the Predimed Plus, and of course, that's the best approach. Adequate calories, however, are needed in some maybe populations, in frail patients, older adults. This is a statement from the ESPEN guideline on older patients, nutrition in older patients. And calories are needed especially for, let's say, using amino acids in an anabolic way in some conditions, because otherwise they might be oxidized. I didn't use the Predimed Plus slides because I knew that Jordi will present it. I am very excited to see that there is a protection on the body composition from the Predimed Plus data, which is very meaningful and important. But of course, quality of calories is also an issue, and I will not go very much into detail because Jordi already mentioned that there is not only the Mediterranean diet, there are also other healthy diets and therapeutic diets, but this is very important. In some populations, however, we may also need to ensure that protein and calories are also maintained at least at isocaloric level when there is a very strong catabolic hit, which will make disproportionate loss of muscle mass more likely if we don't replace the calories. I would like to summarize more or less, let's say, intuitively that these include acute diseases, catabolic hits, like if you are in the ICU, if you have a trauma, sepsis, and so on. Advanced chronic diseases like hemodialysis patients, end-stage terminal chronic diseases, and major catabolic treatment. In these cases, you might need surgeries and chemotherapy in cancer. You might need to preserve caloric intake at least eucaloric level. This is an example also for protein. When you have these catabolic conditions, this 1.2 might become even higher. This is the ICU guidelines for ESPEN nutrition in ICU. The recommendation also for obese patients in general, without sarcopenia, is 1.3 adjusted body weight, gram per adjusted body weight. Maybe in sarcopenic obesity we need higher. We don't know. There is no research. And again, this is the anabolic role of isocaloric treatment, which is also recommended for obese patients in the ICU. This is other examples from ESPEN guidelines. Liver disease, acute illness, or acute preoperative, some conditions, you may see the numbers here. 25 calories per kilogram ideal body weight, 2 to 2.5 grams per kilogram of ideal body weight protein. This is quite ambitious, but it is recommended if you have a risk of malnutrition and acute illness with obesity. Micronutrients, I try to go quickly. I see 26 minutes, but I hope it's the total of the session. Okay, I haven't been speaking for 26 minutes. Okay, micronutrients, very quickly. There is definitely a risk of deficiencies for micronutrients in obesity. We know that, and we should not really take it lightly, but sometimes it is neglected in clinical practice. We know that there are established risks for deficiency of several micronutrients that may have an impact on sarcopenic obesity in terms of adipose and muscle metabolism. So there is a strong rationale to use micronutrients. There are problems, however, that there are methodology limits for routine assessment of micronutrients in clinical practice. So it's not easy to do it, but we should probably think more and more and indicate, for instance, we know that bariatric patients have this risk after bariatric surgery, but maybe also before low-calorie diets, before pharmacological treatment, we should more and more, at least at-risk patients for sarcopenia, introduce screening for micronutrient deficiencies and treatment following. This is the rationale that I was mentioning. I will go very quickly, but I would like to say that some of the micronutrients that we are considering more commonly have really the rationale to treat both the adipose tissue derangements and the muscle derangements that characterize sarcopenic obesity. So they have a really pathophysiological role, and I think that's very important. This goes for PUFA and vitamin D. Unfortunately, we still have a problem with the micronutrients in terms of consistency, I would say, of treatment protocols. Sometimes we have different doses, different combinations, different duration. So the evidence, when we look at meta-analysis, and of course this is still lacking the evidence for obesity patients, is not very convincing unless you have a proven deficiency. For instance, with low vitamin D, there has been a demonstration of a positive impact on muscle mass. So we need much more research, but nutraceuticals and micronutrients need to be considered, especially if there is a deficiency. I would like to, I hope there's no embargo here for this figure, which will appear in our joint paper between ESPEN and DNSG, or DNSG and ESPEN, on nutritional provisions for sarcopenic diabetes, which will hopefully be published very soon. And you can see that we are really summarizing what I just tried to summarize in my talk. I will not go into detail, but this is really, for us, a very meaningful paper, and I really appreciate the opportunity to collaborate on this. I was mentioning very quickly calorie excess. So I will say 1 or 2 minutes something about that. We need to consider that treating sarcopenic obesity is really also treating obesity, or vice versa. And the goals for treatment of sarcopenic obesity should be a little bit larger than the goals that we have for obesity. Let's admit it. Normally, we are just looking at body weight and reduction of body weight. For sarcopenic obesity, the goals should be body composition rather than just weight, reducing fat mass, but also preserving or increasing muscle mass, and increasing also muscle function, because I mentioned that's defining the component of sarcopenia. This is the algorithm that ESPEN and EASO, in this case, have published 3 years ago, which is actually the diagnostic step you can see here is a reduction of muscle function and a reduction of muscle mass relative to body weight. which is, I think, a crucial issue in obesity. It's not the same to have 30 kilograms of muscle, let's say something like that, in a 70 kilo person, relatively healthy, or 35 kilograms in a 110 kilo person. That's not the same, and it's probably not enough, but it's even though it is more muscle in absolute terms. So I would just like to mention that in major studies, this is a New England Journal paper, lifestyle approach in older patients, frail patients, you normally see that you lose 5% of muscle mass in these patients. It's worrying in general terms. It's not good, but you lose 15% of fat mass. And so the body composition improves. The fat loss is also reducing the metabolic load, is reducing the mechanical load, that you can expect an improvement in muscle function, which is also confirmed by this same study. Dietary restriction with loss of muscle mass is associated with better performance, and muscle strength directly measured is also preserved. So I think it's important to look at the full picture, and treating obesity may also treat sarcopenic obesity if it is done well. I just like to mention that I'm very grateful to the new obesity medications, not only because they help us to treat the patients much more effectively, but because they are increasing the attention to sarcopenic obesity. But I think that the same that I just mentioned for the lifestyle applies also for drugs, for medications. There is an improvement in body composition, and the registration studies for semaglutide and tirzepatide has also reported functional improvements in the patient. It's not direct measurement of strength, but it's important to remember that. So we need to check the full picture, not only loss of muscle mass, but also body composition and strength. And also it's just an opportunity for me to remind that these medications and bariatric surgery as well can be implemented safely. We need to also implement lifestyle and nutrition to minimize loss of muscle mass, but we need to look at the full picture and monitor these parameters. So this is my conclusion slide. Sarcopenia is a likely common but underestimated complication in obesity. Higher protein intake, of course, with the resistance exercise is commonly recommended. I think it's a major component of the nutritional treatment. Although we lack the evidence to make optimized recommendations, we need to maybe preserve calorie intake also in some specific settings. These patients might be at least in some acute catabolic illnesses in need for full nutritional treatment. And also treating obesity may treat sarcopenic obesity if we do it right. Thank you for your attention.
Thank you, Rocco, for a wonderful presentation. I'd like to invite Ian Nealand up to present protein intake for lean body mass preservation and weight loss, how much and what types.
Well, thank you very much. I really appreciate the invitation to speak with you today. I'm not a card-carrying nutritional epidemiologist or scientist, so I'm learning so much from everyone here, and I really appreciate the opportunity from the organizers to invite me. So today I'm going to talk about protein intake for lean body mass preservation and weight loss, how much and what types. And I think it's a great segue from Dr. Barazzoni's talk into more about protein supplementation. What do we know, what don't we know, and what should we know? These are my disclosures. So it's known that persons living with obesity have more muscle mass per pound per kilogram than those with normal weights. And with weight loss of any intervention, right, there's a loss of muscle mass. Now, one can think about this in the context of the following analogy. Now, I'm a cardiologist. In the face of uncontrolled hypertension over a long duration, the heart muscle hypertrophies. That's called left ventricular hypertrophy. And that is in the setting of a high afterload, a high stress on the heart. However, when people control hypertension, whether it be pharmacologically or lifestyle-wise, that muscle mass then regresses back towards normal. So although loss of muscle mass in the heart can be thought of as a problematic issue, in fact, it's actually very adaptive, right? And so the concept here is that gain of muscle mass in the context of obesity and then loss of the muscle mass when obesity is ameliorated actually can be a very adaptive process. The other point of that is that the muscle quality, as was spoken about, is also extremely important because patients with obesity and higher muscle mass may have dysfunctional muscle that may not be functionally adequate for their needs. And therefore, even though there's higher mass, it's not as high quality as it could be. So the other point is that per each kilogram of muscle mass lost, we will reduce resting energy expenditure by approximately 13 kilocalories per day, which means that when people lose weight, they'll plateau with their weight loss because their basal metabolic rate will then stabilize and they won't be able to burn as much as they previously did. And that's in contrast to the amount of contributed by each kilogram of fat mass, which is about 4 kilocalories per day. So preservation of muscle mass is very important, not just for the initial weight loss phase, but also maintenance long-term of that weight loss, not to go back to the previous weight the person was at. And so if muscle mass can be maintained or even increased during weight loss, right, could limit this reduction in metabolic rate and concomitant homeostatic adaptations, which lead to slowing and plateau of weight loss. So it's known that short-term calorie restriction, let's say 30% calorie reduction, and I just learned a new term during this meeting, energy reduced, not calorie reduced. I think I'm going to start using that. Decreases the postprandial rate of muscle protein synthesis and maintains or decreases the basal muscle protein synthesis rate. However, what we're talking about really is prolonged caloric restriction, right? Prolonged weight loss. And so the common target of 5 to 10% weight loss will usually actually increase the rate of muscle protein synthesis so that the loss of muscle really is in fact due to increased proteolysis, right? Increased breakdown and destruction rather than suppressed muscle protein synthesis. And this creates a situation where you have a balance of multiple factors at play, right, in order to balance the protein synthesis with proteolysis. And things that can, factor into this whole equation, content, which we'll speak about a little bit later, protein quality, so how the person is able to digest that protein, absorb it, and the kinetics thereof, and then the abundance of the amino acids that's bioavailable for that individual. The format in which the protein is consumed is also extremely important, right? Whether it be a mixed macronutrient meal, isolated supplementation, or free-form amino acids. And so this whole concept, this collective optimization of these kind of factors can potentiate the beneficial effects of other protein kinetic stimuli, right? Such as those mechanical effects of resistance exercise, which I'll speak about. And that results in enhanced remodeling and repair of existing muscle and the prevention of breakdown of that existing muscle and potential synthesis of new muscle proteins to provide continued maintenance and growth. So this is a slide that shows a relationship between percent body weight loss and the percent lean mass loss in multiple studies between both lifestyle, the diet, pharmacologics such as incretin agonists, and as well as bariatric surgery. The rule of thumb generally in the literature has been that 25% of all weight lost in the setting of weight loss is muscle mass or lean mass. And the issue with that is, first of all, lean mass is not a great surrogate for muscle mass. Lean mass incorporates not just muscle, but other tissues as well. And so for years, the gold standard, so to speak, has been DEXA to look at lean mass. But DEXA has a lot of limitations because you can actually look directly at muscle mass. And so there's a movement and a shift in many studies, such as some of the new tirzepatide studies, to look at MRI. And MRI can actually directly quantify muscle. So this was a figure that we had in a recent paper. My collaborator, Andreas Birkenfeld, put this together. And what you can see is that although they're not superimposable, there's a certainly linear relationship between percent body weight loss and lean mass loss, with potentially a little bit more with incretins, a little bit less with diet compared with bariatric surgery. But in general, with any intervention for weight loss, you will lose lean body mass. And the graph, the table at the right, shows you several GLP trials, semaglutide, tirzepatide, and liraglutide. And if you can see that there is a wide variety of the percent of lean or muscle volume lost, anywhere between 15% with liraglutide, upwards of 45% with semaglutide. And then in one of the studies where you had liraglutide plus exercise, they actually gained muscle. So, there's a lot out there and that we need to know that we don't know yet with these medications that we're looking into. So the current dietary protein recommendations, at least in the United States, are that the recommended dietary allowance for protein for the standard individual is 0.8 grams per kilogram of body per day of body weight. And that translates to about 0.36 grams per pound of body weight. So for a person weighing 150 pounds, you would need approximately 54 grams of protein daily. In addition to that, there's a recommended distribution of macronutrients that you take in based upon your total caloric intake. And the recommended distribution is between 10 and 35% of calories should come from protein. And the current RDA really was developed from nitrogen balance studies as a way to understand the minimum intake we would need to make sure to prevent a negative nitrogen balance. So it's really what we just have in stable life. However, when we're losing weight, be it any intervention, we need to consume higher amounts of protein typically during moderate energy deficient weight loss, because that will potentially improve muscle mass in an otherwise catabolic physiological environment. And so when you really have a large amount of weight loss, as we're seeing, for example, with GLP related therapies or bariatric surgery, where the caloric deficit increases beyond 40% of energy needs, so a greater proportion of those dietary amino acids are utilized for energy production and thereby do not go into preserving muscle synthesis and proteolysis. So with moderate energy deficit, protein intakes in the order of double the current RDA, something like 1.6 grams per kilogram per day, have proved efficacious in some studies preserving muscle mass during weight loss. In addition, protein supplementation can have other beneficial metabolic effects. This is a study that we did with Nestle, where they came up with a protein microgel, which is a very concentrated whey protein formulation. And we fed it to people who, before they ate pizza, and 2 days apart. And we wanted to see what the immediate effects from postprandial glucose excursion as well as GLP-1 response would be in those individuals. And indeed, the whey protein supplementation shortly before the pizza meal increased the GLP-1 response by 66%, and reduced the postprandial excursion of glucose by 22%. So you can see that the protein supplementation, even in the acute setting, has potential positive metabolic effects. In addition, it reduced, it augmented insulin secretion and also augmented amino acid bioavailability by upwards of over 200% for these patients. So again, these whey protein can be important both for initial metabolic needs as well as for long-term muscle homeostasis. So let's get into a little bit more about, how much protein, what protein, and how should we think about this? From clinically, it does make a lot of relevance. I mean, there are patients now with GLP-1 receptor agonists being prescribed with weight loss, lifestyle interventions, which are certainly important. So what about simple protein supplementation and dietary weight loss, right? Just giving protein in the absence of anything else. So this is a study of 70 middle-aged postmenopausal women with obesity who were randomized to either weight maintenance intervention, weight loss with the RDA recommendation of 0.8 grams per protein per kilogram per day, or weight loss plus a supplementation up to 1.2 grams per kilogram per day. And what they assessed was that thigh muscle volume, as well as strength at baseline, and then at 5 and 10% weight loss in the weight loss groups, to understand with each weight loss period what the difference would be in the protein supplementation, and then a time match group for the placebo group. So it turns out that although there was a small benefit and a reduction in thigh muscle volume loss at 5% body weight loss in the supplemented group versus the non-supplemented group, the differences were very minimal to negligible at 10% weight loss. And so over time, I think this is consistent with actually some data we saw in the previous talk, was that protein supplementation alone in the absence of anything else may have small initial changes, but is not long-term sustainable and doesn't really provide a long-term benefit for muscle, especially at higher amounts of weight loss. And you can see here that there was some improvement in intramuscular adipose tissue changes and then a reduction in muscle volume loss. So adding resistance training to protein supplementation is considered to be the appropriate method to really preserve muscle. And as you can see from the raglatide study we had previously, as well as the studies I'll point out here, is that marrying resistance training with protein supplementation is actually not just preserves muscle, but can potentially build muscle in the setting of weight loss itself. So this was a study of 208 adults over 1 year that were randomized to several interventions. And you can see that in those who got a high, heavy resistance training protocol, plus protein supplementation, they had not just preservation of quadriceps cross-sectional area, but also improvement in the isometric contraction force and other functional outcomes. So really, it's important to tell patients to understand that protein supplementation plus resistance is important. And this is another trial, or several studies that were put together that essentially showing that untrained individuals, which is mostly who we're talking about in a clinical setting, changes in lean mass and muscle mass observed during the initial weeks of resistance training are not influenced when protein supplements are provided, but the duration and frequency of as that intervention increases, whether you're untrained or trained, actually protein supplements can promote greater gains in lean mass and muscle strength. So there is potentially a synergistic aspect to protein supplementation with resistance exercise, where either one in isolation may provide some benefits, but together they may be the best and sustainable. And this is another study that I think is interesting, because this study looked at a randomized intervention of resistance exercise over 6 weeks with dietary protein supplementation. And what you can see here is the change in fat-free mass as a function of total protein intake over per day. And what you see is there's a linear relationship with increasing fat-free mass with total protein intake, but it levels off at 1.6 grams per kilogram per day. So as we discussed before in the previous talk as well, there is probably a benefit to a higher protein intake than the recommended daily allowance, but at over 1.6 grams per kilogram per day, there probably is diminishing returns. And so there's probably the sweet spot of what we should consider. In terms of types of protein supplementation, so you can either have whole food proteins, be it plant-based proteins, beans, peas, lentils, nuts, seeds, and soy, or animal-based proteins, both from meats and fish and dairy. And then there's supplements, right, such as protein powders and plant-based combinations. And so protein powders, such as using from whey, from dairy, or casein, also from dairy, are very popular now, and also speaks to the plant-based diet. And the issue, though, is that plant-based protein sources generally have a little bit lower amino acid profiles and somewhat reduced bioavailability compared with the animal sources. And there's also some data to show that high leucine content can be important for muscle protein synthesis, such as coming from whey, for example. And soy and plant-based sources generally have lower leucine content. That being said, I think that there's other benefits to a plant-based diet beyond just the amount of protein one can ingest and is bioavailable to them. And so I think from any source that you can get it from, as long as you're getting the appropriate amounts and the appropriate methods, it's going to be beneficial. And this is one study that essentially shows what I just said, is that no matter what the source, be it milk or soy, there's potential benefits when it comes to sarcopenia, for example, and muscle health. So in summary, prolonged caloric restriction for weight loss increases muscle proteolysis, and mitigation strategies obviously need to focus on reducing muscle loss and preserving existing muscle. Weight loss strategies of all types will reduce lean mass proportional to the magnitude of weight loss. And with moderate energy deficit, protein intake on the order of about double the current RDA is most likely going to prove efficacious in preserving muscle mass during weight loss. Protein supplementation can also reduce postprandial glucose response and increase endogenous release of GLP-1, as well as branched-chain amino acids. And protein supplementation in isolation without concomitant exercise training has little impact on muscle preservation, especially long-term in weight loss. And protein sources can obviously come from animal or plant-based sources, either whole foods or supplements. And even though animal-based proteins probably have a better bioavailability, I think there's no real consensus on which the source is better to preserve muscle during loss. I think just that as long as one focuses on a healthy diet, increased protein supplementation, and resistance exercise, I don't think you can go wrong when it comes to weight loss and muscle preservation. So thank you very much.